We are here for the Clinical Application of Longevity Medicine 2026 in the beautiful Fort Lauderdale. And today I have Dr. Brooke Ahnemann, and she is here with Dutch, which is one of the advanced diagnostic tools that we went over at the lectures. And so tell us a little bit about the Dutch organization and a little bit about the testing program.
Yeah, so Dutch is dried urine test for comprehensive hormone. So we are looking at hormones in dried urine, which gets you looking at both production and metabolism, which can make a big difference for a lot of patients.
Yes, absolutely. So one of the biggest things that we do in longevity medicine is optimizing hormones. And in my lecture, I talked a lot about the serum blood levels tell you that there are hormones present. So it's like, yes or no, are they present? But looking at it through the lens of an advanced tool is like looking at it from a 3D lens. And so a lot of times I say this is the blind spot when it comes to hormone optimization is you don't know where these hormone metabolites are going. So if a practitioner is starting someone on hormones, how long before they should consider offering a Dutch test?
Yeah, we do have some providers that do a baseline before they start hormones. I will say that's not the rule for most, but sometimes if you have a patient that has a strong family history, it can be really preventative to do that. But once they're on hormones, we say get them to a steady state. Sometimes you have to do a few dose adjustments in that first startup. So get them to a steady state, and then probably about 6 to 8 weeks later is a good time because that's when you're going to see the metabolism at its most accurate. You're going to see good levels coming through at that point.
So let's talk about the differentiator between where blood levels fall short. Let's start with one of the most, I feel like menopause is having its moment right now.
Sure is.
Let's talk about estrogen. As practitioners on serum, a lot of times we'll start with checking estradiol levels. But let's break down a little bit. How does the Dutch test look at estrone, estradiol, and estriol, and why that's important?
Yeah, so by looking at all three parent hormones, it gives you a better idea of that total estrogen exposure. So you can measure those in serum, but we're measuring them always on the Dutch test. So again, you're getting a more comprehensive picture, and they are still somewhat estrogenic, so they can be having an effect. And then they do all have their downstream metabolites that are, again, adding to that estrogen burden on the body. So you could have normal estradiol levels, but have high estrone or high downstream metabolites, and that patient doesn't feel very good.
Right. So we talk about the protective, the proliferative, and then the carcinogenic.
Yeah.
Talk about maybe some of the clinical picture symptoms that someone would see where perhaps the estrogen is not methylating or it's not going down one of the phase pathways that it needs to.
Yeah, if everything's going as it should be going down that protective pathway. It should be clearing out through phase 2 methylation. It should also then be getting out of the body, right? We don't talk about phase 3 or measure it, but that's also important, elimination. When it's going down one of the other 2 phase 1 pathways, that's where we start to see a lot of problems. That 16-OH pathway is the proliferative one. It's more estrogenic, like you mentioned. So in a lot of younger women as well as women we put on HRT, we might see things like breast tenderness, sometimes mood changes, heavier bleeding when they're cycling. So migraine triggers even sometimes. So it's not optimal long term to be moving down that pathway. So we want to optimize that. And then that 4-OH pathway, that's the one that's genotoxic. So potential increased cancer risk, which we always want to mitigate, especially when adding in HRT, but even when we're younger and have our own estrogen levels are a little bit higher. So there's ways that we can kind of improve these pathways if someone's not moving down that 2-OH pathway that's protective.
Right. So I believe it was Mark Newman had published a paper specifically on looking at the 2 and 4-OH pathway, and it's not necessarily saying lower this and you're going to lower your risk of cancer.
Right.
But talk through a little bit about why would that be potentially beneficial in lowering risk amongst other inflammatory issues as well as the rise of the carcinogenic one.
Yeah, that 4-OH pathway, it damages DNA, right? So it is inflammatory, it's causing oxidative stress in the body, and that's where that increased risk is coming from. The more that's around and the longer that it's around, the more the risk is there. So again, to kind of be preventative both in short term and long term, we want to move away from that. Right. And sometimes it can be both the levels of the metabolite, but something we really focus on is the ratio of how much protective 2-OH we have to that more genotoxic 4-OH. And that can be really important even when estrogen levels are low to see that we have a good metabolism.
Right. I think one of the common issues I see in women's health, especially women have never been more stressed. I don't know if you got to hear my talk yesterday, but women were just stressed all the time. And so one of the common things is how do we teach them how to cope? How do we teach them how to improve their stress levels naturally? So in our practice, we talk a lot about sleep, nutrition, mindset, going to bed at a decent hour, not using wine to wind down, right?
Yep.
And so one of the biggest things I would say is I can give you all the peptides and supplements, but if you're not doing just the basic lifestyle things, it's not going to improve. So can you talk a little bit about maybe some of the research that we see specifically with alcohol, using alcohol, and what we see on the Dutch test as far as that CYP450 pathway and those metabolites?
Yeah, for sure. And I really actually appreciated in your talk yesterday the pyramid, because it is those foundational things, the lifestyle, the diet.
It's the stuff nobody wants to do. They're like, give me a peptide, give me a supplement.
Exactly. But it's an uphill battle if you don't do those things, and I
Yes.
can't fix it.
Yes.
But alcohol specifically, like, we know it's disruptive to sleep. If you're not sleeping, everything else is off.
Right.
It is inflammatory. And then specifically in the estrogen metabolism, it actually pushes of those P450 enzymes, there's the 3A4 enzyme. That's the one that's metabolizing alcohol. So you're more at risk for that more estrogenic proliferative estrogen, even with moderate alcohol consumption. Like, the research really says, like, even a glass of wine, which sometimes we're like, no, that's good for
It's
me.
got
I should
resveratrol.
totally
This is for
have
my heart.
that. And it's like, no, you're going to have more of that proliferative estrogen and worsen your heavy bleeding. Like, don't do that.
Right.
So yeah, and some people are more susceptible than others, but it's definitely not ideal. Your liver's processing hormones as well as alcohol, so the more burden there, the harder it is on your liver.
Shifting gears, one of the things I really appreciate about the Dutch test is how it breaks down cortisol. So can you talk a little bit about, I'm sure a lot of practitioners get this question, well, can I just check my serum cortisol level? And I talked through a little bit about this, but from a clinical perspective, can you explain why a cortisol awakening response is far more beneficial than looking at just a snapshot in time?
Yeah, so the snapshot in time, like, what's happening at that moment? If they're going and getting a blood draw and they're stressed out, you're going to see high cortisol. Well, what does that mean? Do they have a functioning HPA axis, or are they just burnt out and flat and high all the time, low? So it doesn't give you much meaningful data about, like, what's happening throughout a day. The cortisol awakening response is like a mini stress test. We're measuring in saliva, right, that first hour of waking. And it is a moment in time, but it's how you respond anytime a stressor comes along. So it's like, did your kid have a bad day? Like, did you get yelled at work? Like, you're getting these tiny cortisol, well, if you have a high responsive car, you're getting these tiny spikes of cortisol, like, throughout the day, which can be bad for blood sugar, bad for inflammation, or you're totally burnt out and you're not responding at all. And then we have some problems where we need to get that brain talking to the adrenals again and improve that HPA axis for sure.
Absolutely. I think one of the things that I find it so fascinating is when you're looking and comparing the cortisol production to the cortisol clearance.
Yes.
So can you differentiate, why would a practitioner want to actually look at the clearance? Because I think that really gives us some clinical insight as to why do they feel like they're crazy, or why do they have no motivation to do stuff, or why are they overwhelmed by everything?
Yeah, and that adds, again, like, with cortisol, we're looking at more of a three-dimensional view. So if we're looking in, like, saliva, if we're looking in blood, we're looking at free cortisol, which is about 3 to 5% of production. It's what the tissues have to use, gives us that diurnal pattern, but doesn't really tell us about how much output the adrenal glands are making of cortisol. So we can look at that in the metabolites, which we measure. So we have a look at the total production. And then if we expect, well, if you're making a lot of cortisol, you should have high free cortisol. If you're not making much, it should be low. That would be a normal clearance. If you don't have a normal clearance, there's something else going on. So you may have an adrenal problem, but you may also have a thyroid problem or insulin resistance or something else going on that we need to dig a little bit deeper. And the Dutch is really great at that because it tells us these hormone stories, but the hormones are also often telling us about other things happening in the body. So we have to start looking at some other things too.
Yeah. And I think one of the coolest things that I see in clinical practice is when initiating measures to help improve insulin, how much benefit we see on the androgen side.
Yeah.
So yesterday I presented twin sisters, right? Clinical
I
case.
love that.
same, essentially the same labs, twin sisters. 6 weeks later, one's feeling amazing. She's thriving in life, playing pickleball, likes her husband again. The other one is a disaster. And the preclinical information was the slight difference is one had an insulin of 20 and was essentially pre-diabetic.
Yep.
So talk through a little bit about what impact would correcting insulin. So let's say I initiated a GLP-1 with this patient. What impact would that have on the androgen side of the Dutch test?
Yeah, so in looking at the androgens, it's the metabolism. So when there's inflammation, when there's insulin resistance, we go down, like 5-alpha reductase is upregulated. And so that then pushes us down a more androgenic pathway. So again, we could have normal testosterone levels or potentially high, because androgens are kind of production is upregulated as well. But we're then going down this more androgenic pathway and going to make more potent androgens and then be more likely to get those high androgen symptoms, the acne, the hair loss, even when we have normal testosterone levels. And so we might not respond well to some testosterone replacements.
Right. So when I teach practitioners, I say, we have direct interventions and we have kind of indirect interventions. A direct intervention on a high 5-alpha would be spironolactone. I'm just going to correct the problem that I see, right? But this is why I think a Dutch test can be so helpful, because you can correct the insulin, which will then in turn correct the 5-alpha reductase.
For sure.
Which I think is so cool to use those diagnostic tools and then to use the clinical reasoning. Well, this is the downstream issue, and that's where truly a Dutch test is, I think, the most beneficial. Another thing that I really love about the Dutch test is, let's talk a little bit about the organic acid piece of this. And I think what's hard for new practitioners getting to this space is they look at it and it's just like overwhelmed, right? It's like a Sudoku puzzle. But I think the more that you do, just as you said, it's pattern recognition. It's you'll see it as someone trained in interpreting this, and then you'll ask the question, well, do they have this? And the practitioner will say, well, how did you know that? Because you see pattern recognition. So let's talk through, where does the organic acid test fall into clinical outcomes and clinical decision making?
Yeah, we've been very specific about the organic acids that we've chosen to include on the Dutch test. They all have a relationship to like our hormone health. So we're looking at certain nutrients that may impact hormone health, or B vitamins, glutathione, because inflammation again can impact our hormones. We have a gut marker. We're looking at some neurotransmitter markers. So they all kind of feed back into looking at that comprehensive view of our overall hormone health. There's more extensive oats tests, but ours are very much focused on being relatable to the other parts of the test and that hormone health piece.
Absolutely. So breaking that down just a little bit more, in the organic acid section, again, one thing I can appreciate is the indican level. So when I see that the indican is elevated, I go back to, which true functional medicine, we always start with the gut, right? Like we all know that. We should have been cleaning up the gut anyway. But it's just another diagnostic, piece. We've got to go back to the gut.
For sure.
The other one that I actually can really appreciate, and this is where some of the peptides can be helpful, and some of our nutraceuticals like tryptophan, is looking at dopamine. So can you talk through a little bit about why those neurotransmitters are on there and what impact that would have on hormone health?
Yeah, so they're really reflective of like adrenal health, right? Because that's kind of where they're coming from primarily. So a lot of times we'll see a lower HVA, the marker of dopamine, when we see really low adrenal output. And we may want to support dopamine in patients that are having low dopamine symptoms. At the same time, we're also trying to correct adrenal function. So there's kind of a lot of times this give and take of like, let's support the short term while we're working on those deeper root cause things as well. So,
Talk a little bit about, so I would say Dutch had a facelift, and so I like the front sheet now is the Dutch dozen, right?
Yes.
So talk through, why did you change it?
Well, like you mentioned before, it's a complex test, and so we find a lot of our providers can initially find it very intimidating, and a lot of our providers have struggled to explain it to their patients. So we wanted to try to make it easier for everybody. We're always trying to support our providers, and we've listened to that feedback. So we've brought all of our most relevant markers to that very first summary page, and honestly, that page is a really great place to tie a treatment plan so you don't get into the weeds with your patients. You can can just walk them through this page and say, like, we see this is the treatment for that, without having to like have them muddle through that metabolism and all the drawn out pieces. So we've tried to streamline it for it and make it a little easier to read, which I'm glad to hear it has.
I appreciate that. The other nice modification has been like the slider dial. Which I, again, as someone, and I'm training practitioners and they're like, hey, I need your help before you go and see your next patient. I say, show me the front page. And I'm able to at least help, ask questions and kind of guide them. I would say the next thing that I find interesting is how the progesterone is broken down. So can you talk through a little bit about one thing I'm seeing a lot in clinical practice is histamine. Histamine surrounding progesterone. And I don't know if it's because I'm asking it more. I don't know if it's because I'm posting about it on social media, but I'm like, why is everyone having like mast cell issues with progesterone or lack of progesterone, or it's causing the mast cell? Can you talk through a little bit about that correlation?
Yeah, honestly, like the patients that aren't tolerating progesterone, I often think about gut health and liver health in that case. I don't necessarily say that I've seen a direct pattern on the Dutch test, but we're definitely looking at like progesterone metabolites, which can have relevance for like symptoms, more from like the benefit that we're getting from progesterone for like mood and sleep sorts of things. We're not usually monitoring levels once someone's on progesterone replacement. We're more looking at that metabolism and are they moving down an alpha pathway. But I've definitely seen like the histamine response. But again, I start to think about like what's happening in the gut, what's happening in the liver. There's something else. Why aren't they responding well?
I tell patients a lot of times, if your body's having a histamine response or mast cell, that is a symptom of another deeper issue. Do you have like a chronic underlying infection? Is there something that we've missed along the way? So I do think that is important to understand. Can you talk through a little bit about how progesterone, so I get this question a lot, comparing topical progesterone to oral progesterone, and there is an educator who is very well known on social media talking about oral progesterone is too much, and it can impact.
We've had some conversations this weekend.
Oh, I'm sure you have. I'm sure you have. So can you talk through a little bit about, what are your thoughts on that in clinical experience, in that I know that I see when I give oral progesterone, it can be very calming. I would say it's like nature's Valium because it breaks down into allopregnanolone, which hits the GABA receptors of the brain. But can you talk through a little bit about the differentiator between topical progesterone and oral progesterone and what impact that would see on the Dutch?
Yeah, so with oral progesterone, we get first pass, right, where a lot of things are just being cleared from circulation and being dumped out. So we get high metabolites. That allopregnanolone is a metabolite of progesterone. So we get higher levels of that with oral progesterone, and that's what crosses the blood-brain barrier and gives us that calming GABA support, right? Topical, the question is how much is really systemically absorbed. Progesterone's a slippery thing to measure no matter how you're measuring it. So we don't see serum levels go up, and similarly we don't see levels on the Dutch go up very much. Oral progesterone also has really good research. It's the standard of care, right? If you're given like estrogen for that uterine for protection. So, and the alternative there that is also protective would be vaginal, but you don't get those systemic benefits again of those higher metabolites that give you the GABA support. So it's a give and take in what you choose for your patient. But the topical, the research doesn't back up that protective piece, and you're not getting the benefit of the metabolites there.
Absolutely. So if a practitioner's listening, they heard my lecture, they're like, I need to start doing Dutch tests. What is the best first step for a practitioner to get signed up? And then I know you guys have an amazing education portal.
We do.
So talk through a little bit of how do you get signed up, and then where would we start here?
Yeah, so to sign up, it's really easy. You just have to go to our website, dutchtest.com. There's become a provider, fill that form out. Our team will then reach out to you, get that account set up. That gives you access to our provider portal, which is where we have our provider-focused resources. We've built some courses, we have some treatment guides, and we have a really big, strong team of clinical support, like myself, on staff, ready to help you walk through all the questions and test results as well.
Yes. So I would say don't let the intimidation be the reason why you don't do it. Again, they have amazing resources, and then as we continue to work with New BioAge and more education, we're just going to continue to collaborate together to make the next generation of practitioners stronger in hormone metabolite testing.
Yeah, that's what I think we all want to support our providers, right? So that you can support your patients. So we believe really strongly in doing that. So.
Well, thank you so much for taking the time. We've enjoyed working with you, and hopefully more practitioners find the value in Dutch testing.
Thank you so much.